So a very good afternoon to everyone, and good morning to our speaker, Kate. It's my privilege to moderate today's session of the Toxicology Forum of the Sri Lanka College of Paediatricians. Our focus today is on an immensely important topic, an approach to pediatric poisoning in low middle-income countries. We are fortunate to have with us a poison scent expert who has dedicated her career to advancing pediatric toxicology in such settings. It's my pleasure to introduce Dr. Kate Balme, a distinguished medical professional whose work spans pediatrics and clinical toxicology. Dr. Balme has been an integral part of the Red Cross War Memorial Hospital Poison Information Center in Cape Town, South Africa. She has been serving there for the past 15 years, and she has made an invaluable contribution by developing poisoning treatment protocols for both children and adults, and collecting and publishing critical data on pediatric poisoning, presenting to hospitals, and offering guidance through the Poison Information Helpline, helping to save countless lives. And her academic journey is equally impressive. She holds an MSc focused on the use of antibiotics in children with paraffin injection. And currently, Dr. Balme is pursuing her PhD on acute poisonings in the Western Cape, South Africa. And her interest extends to some of the most challenging aspects of toxicology, including pediatric pesticide poisonings, environmental toxins, and envenomations from snake bites and scorpion stings, topics that resonate deeply in many lower middle-income countries, including that of ours. So today we have the opportunity to learn from her expertise and experiences. So please join me in warmly welcoming Dr. Kate Balme to deliver her talk. Over to you, Kate.
Good morning, everyone, and thank you so much, Prof. Dayasiri, for the invitation to speak today. It was lovely. We got to know each other at a recent meeting in Penang, Malaysia, as well as we are together on our journey of PhD pursuance. But thank you so much for asking me to speak today, and really to focus a full talk on pediatric poisoning in lower and middle income countries. It really is a great privilege, so thank you. I'm just going to move to sharing my talk now, and then I'll highlight what we're going to do today. Right, so I'm just checking in that you can see my talk there. Is everybody, is it sharing okay?
Yes, we can see that, yes.
Okay. And I think I'm just going to turn off my camera. Sometimes it interferes with the quality of the talk presentation. So I'll do that for now and turn it back on at the end again. All right, so this morning, really what I want to do is to start by highlighting the prevalence and impact of childhood poisoning globally, and comparing South Africa and Sri Lanka as examples of low and middle income countries. I also want to talk about the resources we have available for treatment and data collection in South Africa specifically. And then lastly, we will go through a generic, simple approach to the treatment of poisoned children, and use it in highlighting some of the more common toxins that we all see in lower and middle income countries. So firstly, let us talk about pediatric poisoning and actually put it in context and understand why we spend so little time learning about it. These tree maps here, which are from the Global Burden of Disease Project. And like I said, if you're not familiar with this, please have a look at it my references at the end of the talk. So these show deaths for 2021 globally in the top figure, and a small dot in the green fields shows poisoning. And the green ones indicate injury-related deaths. And globally, for all age groups, poisoning accounted for only 0.083% of deaths for all ages, and 0.12% of those in children under 5, which is the bottom figure. Please also note how when all ages are included in the top figure, the blue deaths are dominant, which are due to non-communicable diseases, Whereas when we move to children under 5 years in the bottom figure, as you all know, the overwhelming illnesses remain those in red, which are due to communicable conditions and nutritional disorders. And the key on the right indicates whether or not there's been an annual increase or decrease in the numbers. So I think we can see that for poisoning, there's a bit of parity, perhaps a bit of an increase in numbers for children under 5. But really, these figures are meant to represent how poisoning is not a common occurrence in many countries. And so that's why we learn so little about it. And often it's not covered in things like medical school and training because it's not always the biggest burden of disease. If we look at just the injury-related deaths in children under 5 years, in Sri Lanka, which is represented by the top figure, poisoning accounted for 0.028% of all deaths. And in South Africa, at the bottom, it accounted for 0.14% of deaths. And out of interest for this audience, animal contact accounted for 0.11% of all deaths in Sri Lanka and only 0.084% of deaths in South Africa. And that's for children under the age of 5 years. But where do these numbers actually come from? As we know that data from our countries are hard to come by. I don't have the answers for us, save to say that these figures are likely quite inaccurate. Not to mention that for pediatric poisonings, deaths are perhaps not a good indicator for the burden of disease. As we know that most pediatric cases are accidental and small exploratory ingestions, whereas adults are either exposed in the workplace to highly toxic chemicals or take large intentional overdoses of multiple substances. So this, of course, makes a difference to how they present and the associated morbidity and mortality. So why is it important to know the real figures in our countries? As we all know, we must monitor trends in order to improve treatment, to develop targeted prevention campaigns, and to inform policy at a government level. You will all be aware of the tremendous impact that banning paraquat had on suicide deaths in Sri Lanka after the number of cases were presented to the relevant decision-making authorities. The aim is to ultimately reduce the numbers even further. On this graph, the bottom orange arrow shows South Asia, which of course includes Sri Lanka, and the top blue arrow and line represents sub-Saharan Africa, where South Africa would fit into this group. And the middle red arrow and line indicates all lower middle income countries. So over time, all the numbers have been declining, but really we need to see further decreases in our numbers. And of course, we all know where the high income countries sit, which is right at the bottom of this graph, with comparatively few cases. But it seems to be a lot of the research and the money is focused in these areas. So what resources are there available to us to monitor childhood poisoning? From what Professor Dayasiri said, these are lacking in Sri Lanka. And so that's why he's asked me to tell you about some of the ways that we collect data as well as provide poisoning services in South Africa. We have 2 large poisons information centers, each of which have been in operation for over 30 years now. I chose these pictures to showcase our beautiful Table Mountain in the background, but also to highlight that both poison centers are actually found in Cape Town. The PIC that I work at is the Red Cross War Memorial Children's Hospital one on the left. And although we are situated at a pediatric hospital, we do cover the realms of adult poisoning too. The second main PIC is at the Tygerberg Academic Hospital, which is shown on the right. Both hospitals are tertiary centers as well as training centers for the 2 big universities in Cape Town. Although neither poison center admits patients to their own toxicology unit, each one is available to advise on cases admitted to their respective hospitals with the diagnosis of poisoning. Since 2015, the 2 poison centers combined their expertise to launch an essentially national poisons information helpline, running 24/7 and available to members of the public and health professionals for assistance with managing poisonings. Unfortunately, due to austerity measures, we've recently had to cut the service hours, but we're hoping to be back to 24 hours earlier on this year. We receive well over 1,000 calls a month. And as you can see from the accompanying graph, we are busier over the summer months. And about 2/3 of our calls come from healthcare workers who are mostly doctors. And this is just an image of one of our colleagues taking a call in our centre. Every telephone call is logged in a specifically designed database program called the AfriTox Telelog database, which makes for an excellent source of national poisoning data. And this chart shows the types of toxins seen in children under 12 years for 2022. As you can see, almost half the cases were related to pharmaceutical exposures, which are both over-the-counter and prescription medications. Next were household or handyman chemicals such as bleach or kitchen cleaners, the laundry detergents, thinners, and kerosene. And third commonest were exposures to pesticides. Looking at the data more closely, we see that children 12 years and younger made up 46% of all calls received in 2022, with 80% of these being in children under the age of 5 years. The table on the right lists the substances that cause the most severe signs and symptoms for the under 5-year group. And medications were most frequently, particularly psychiatric medications, and then anticonvulsants, some cold and flu remedies, and the analgesics. Secondly, pesticides, and particularly organophosphates, and then the formamidine insecticides, which are used in cattle dips. Thirdly were antiseptics, and specifically potassium permanganate, which is a corrosive agent. And then lastly, of course, kerosene. And I'm sure all these agents are very familiar to your experiences too. In addition to using these data for health department reporting, we regularly present at conferences as well as publish in relevant journals. On the left is a poster presented to a conference on snakebite, and on the right was ivermectin calls that we had received during the COVID pandemic, and there was an increase in numbers due to people using it irrationally or irresponsibly or out of what it was intended for during the COVID period. The second way the Red Cross Poison Centre collects information on pediatric poisoning specifically is by collating cases that are admitted to the hospital with a diagnosis of poisoning. And one of my job requirements is to collect these cases weekly and enter them into a database. And from these figures, we can monitor trends, as well as hope to inform best practice for the management of cases within our region. The other resources that are integral to providing a poison centre service and managing cases are, of course, treatment guidelines. And in this space in South Africa, we have a number of options. So common poisonings are covered in our National Department of Health Standard Treatment Guidelines. There are poisoning chapters in both the adult and pediatric hospital level standard treatment guidelines, as well as an emergencies and injuries chapter for a primary healthcare level, and we contribute to all these guidelines. But AfriTox is our poisons information database, and this is our flagship product that I'd like to highlight. It's developed by the staff at the Red Cross Poison Centre and has over 40,000 products on it, including pharmaceuticals, household substances, chemicals, pesticides, and environmental toxins such as plants and snakes, etc. For those of you familiar with ToxBase, it's similar to ToxBase, except that, of course, it's made specifically for the South African market, but also it can be used in other lower and middle income countries. We've developed it as an online and offline version so that it works irrespective of internet connectivity, as this can be quite an issue across the country in South Africa. Unfortunately, we've not yet made it into an app, though. We haven't had the finances to be able to do that. Afritox is available free of charge to all government hospitals and at a cost for private facilities. And many of the common pharmaceutical products and their treatment protocols on Afritox we've also shared with an app called EM Guidance, which is available to anyone in South Africa who's registered with our Health Professions Council. And we're actually currently in discussions with EM Guidance as to whether or not they want to have the entire Afritox offering to share with their members. If you'd like to learn more about Afritox, please visit the website and send any inquiries. We would really love to hear from you. So moving on from treatment guidelines, they may or may not require toxicological analysis, and a laboratory is not always part of a PI service, but can add significant value. In South Africa, we have basic laboratory toxicology testing available via our National Health Laboratory Service. And this includes the usual drug serum concentrations, perhaps the urine drugs of abuse, toxicology screens, etc. And then some of the associated laboratories within the academic universities may also provide additional toxicology testing, excuse me, such as urine mass spectrometry. Forensic testing is also available for all unnatural deaths that go through our mortuary services. Another role that a poison center plays is one of toxicovigilance, and it's how we monitor for trends in poisoning, often due to either drugs of abuse or pesticides or unusual poisons. And one of the ways in South Africa is via notifiable medical conditions. And here in South Africa, we have 3 poisoning-related ones. And they are agricultural or stock remedy poisoning, which just means pesticide poisoning, and then lead poisoning and mercury poisoning. Currently, they are all category 2 conditions, which means that they must be notified within 7 days of clinical or laboratory diagnosis. And I'll come back to that later on in my talk. So the South African National Institute of Communicable Diseases is currently responsible for collecting all the notifiable medical conditions data. And notification can be made using a paper form, which is shown on the left bottom part of the screen there, or preferably and much more quickly and immediately by using the app, which can be downloaded free of charge onto one's phone. The electronic format was implemented in 2018 and had quite extensive associated user training at the time. And then the case definitions for the poisoning notifiable medical conditions were finalized only in 2020, but they haven't had the appropriate training yet, and that needs to be done. So these are the case definitions for pesticide poisoning, which importantly includes all symptomatic cases. And we always have to highlight that it's not just for organophosphates, as this is a common misperception in the medical fraternity. As I'm sure you are aware, pesticides have been shown in many studies to cause more severe poisoning compared to other toxins, with patients requiring ICU admission and longer hospital stays. We've got some inpatient pediatric data from Red Cross between 2003 and 2017, which is in the top table. And this illustrates this quite clearly, showing the high numbers of the sickest children, which are categorized by a poison severity score of 3, which means severe poisoning, or 4, which is death. And these were poisoned by pesticides. Almost half of the deaths over this 15-year period were due to pesticides, and mostly due to organophosphates, or cholinergics, as we often call them, to include the carbamates too. The bottom table shows more recent Red Cross data and compares illness severity by the type of pesticides. And one can clearly see the difference between exposures to the long-acting anticoagulant rodenticides, which are also known as superwarfarins. And these occur very commonly, but seldom result in toxicity. And if we compare them to the poisoning severity of the cholinergic poisonings. We've known for a long time that pesticide poisoning is of great concern. And so the regulated pesticides seen here on the left are store-bought poisons. And unfortunately, the highly toxic pesticides of paraquat and aluminium phosphide are still easily available for agricultural use, but not meant for domestic purposes. And then there are what we call these street pesticides. They are either highly concentrated agricultural pesticides, which have been decanted and used inappropriately for domestic purposes, or they are banned products which have been sold illegally. Of course, as you know, people living in informal areas are desperate for cheap and effective solutions to rats and cockroaches, but unfortunately, such toxic pesticides are also used in suicide attempts and accidentally encountered by children, and they both result in severe pesticide poisonings. And they're sold at train stations and street vendors alongside all the other daily necessities such as food and soaps and all sorts of things, phone chargers. So really it's a mixed bag. In South Africa at the end of last year, these cases again came to light with the terrible death of 6 children. It was proven that they had all ingested the organophosphate turbofos, which has been banned in other countries, but not yet in South Africa. The only upside one can see from these cases is that it has initiated a response from our National Environmental Health Directorate, which falls under the Department of Health. Since then, we are seeing a move to educate medical staff on the treatment of such cases and to regulate the sale of pesticides and even ban certain more toxic ones. The last audit we did before these efforts to look at pesticide notification rates from our hospital alone showed only a 36% notification rate. So hopefully it will improve with this increased awareness. And pesticide poisoning is actually also being looked at to become a Category 1 notifiable medical condition, so that a case should be notified within 24 hours of diagnosis. Moving back to the other notifiable medical conditions that are poisoning ones, mercury and lead poisoning are the other two. And they've been given quite straightforward case definitions relating to blood or urine levels. Mercury and lead are mercury may be found in thermometers or light bulbs, and lead is used in fishing sinkers, in older paints, and in lead solder. And it's usually inhalation of mercury fumes or ingestion of lead contaminated dust particles that results in poisoning. And heavy metal poisoning can actually present quite insidiously in children, more with changes in behavior or some neuroregression, as well as non-specific things like anemia and GIT upset. So having a high index of suspicion is required to make the diagnosis, which is actually quite simply done with either a blood or urine test. And key to treatment is prevention of ongoing exposure. So you must either identify the source and clean the environment, and at the same time remove the patient from the environment. And there are chelating agents available for the heavy metals, but these often take time to get, but often there isn't an urgency for the child to be given them. And in the meantime, one can remove them from the environment and clean up the environment, and often the levels come down quite dramatically. So now that I've covered the resources available in South Africa, I want to cover a quick approach to poisoning with some general concepts. And I'll also use some of the common poisons we see to highlight these concepts. So when dealing with a poison patient, as always, take a good history. So if the ingestion is known, inquire as to how much was taken. It's so important to differentiate between a simple exposure to a harmful substance and an actual poisoning. So this is termed the toxic dose, which is the dose at which most people will experience toxicity. And all further management is based on this. It's used to triage our patients. So whether they are calling from home, presenting to the primary healthcare facility, or admitted in the ICU, as it helps to anticipate the potential severity of a poisoning and decide on the most appropriate level of care for a patient. Toxic doses are easier to determine for medication overdoses, as they are based on case reports for common poisonings. For some medications, just one pill might be harmful, and for others, the whole packet may not be a problem. The toxic dose is a little bit harder to define for household products. Toxicity due to the corrosives and paraffins and things is difficult, and often due to topical or inhalational exposures, and it depends on the concentration and aspiration hazards. So it's not so easy. Some products that I've already gone through here, sorry, that I brought up a bit earlier, I'm sure you've all seen these sachets that come in shoe boxes, which are desiccants. These are not poisonous, but rather a choking hazard, but a common call that we receive. And then some pesticides, such as these, which are the anticoagulant superwarfarins, are often really not a problem in an accidental ingestion in a child. But as I've already shown you, others are potentially lethal. So if a toxic dose has been ingested, then we would have to go forward and manage our patient. But if it has not been ingested, then no further action needs to be taken. So that means don't do gastric lavage or give activated charcoal, and do not admit your patient unnecessarily for overnight observation. We'd like to keep the minor incidents at home and observed by their parents at home, and that's what we use our telephone service for, and that's why we make it available to members of the public, so that the more toxic cases are the ones that are presenting to the already strained healthcare facilities. So I just want to introduce and illustrate how these toxic dose principles may apply to some of the common household products, because for most of them, only a small amount can actually do harm. Unfortunately, kerosene is still in low and middle income countries. I'm sure you see it in Sri Lanka, often decanted into empty water bottles or juice bottles and looks just like water. Even a sip can do harm in a child, and of course the main concern is a chemical pneumonitis. And children present with an inflammatory response with fast breathing and often a fever. And they do quite well with supportive care, perhaps need some oxygen and antipyretics and maybe some bronchodilators. And we've done a study in our country to show that antibiotics should not be routinely given. There were also some child-resistant caps that were handed out by the petroleum industry in earlier years in South Africa, but I'm not sure how available these are today. Corrosive agents such as drain cleaners on the bottom right pictures are often found in household products, and Jay's fluid seems to be a regular culprit at the moment in South Africa. There's even a belief in some communities that it's good for cleaning out the body, and so people drink it either in one go or diluted, or otherwise consume it on a daily basis. And it contains phenols that may cause a corrosive injury. Batteries are also common in the home, and particularly ingestion of button batteries, which can pose a risk, especially in children who have small airways and a small diameter of their gastrointestinal tract. The ingestion of batteries can actually cause injury in a few ways. So, of course, they're a foreign body, which can cause obstruction and pressure necrosis, but they also cause an electrical injury when lodged in the esophagus, which leads to severe corrosive damage. So that is why all patients with battery ingestion require an X-ray. So if they are in the esophagus, they need to be removed with urgency. And if they are found in the stomach and beyond, then they can be, the patients can be observed at home, and just the parents are asked to watch the stool for up to a week. So going back to an approach to management, the route of exposure is always important. As we know, oral ingestion is the most common route, and absorbed toxins cause systemic toxicity. Although ingested corrosive products are more likely to cause local effects, sometimes if enough is absorbed, it may also cause systemic effects. Some inhaled products cause systemic effects, such as carbon monoxide, but others cause more local respiratory effects, such as the paraffin, kerosene-associated chemical pneumonitis. Skin or eye exposure to a corrosive may cause chemical burns, but some substances can be absorbed through the skin, so such as organophosphates, and can cause systemic effects. So the route of exposure determines the onset of symptoms, as well as the options for decontamination. So always examine your patients carefully and pay particular attention to the central nervous system and cardiovascular systems, and always include pupil examinations, observe for muscle fasciculations and strange smells. And these toxic drones may or may not be present, but can be particularly helpful when the history of ingestion is clear. And I've just shown you some of the more common toxidromes. I think the ones we see quite regularly are the anticholinergic toxidrome. We see it in children here, either who've taken antihistamines, or some of our plant ingestions present with anticholinergic toxicity. And obviously the cholinergic pesticide poisonings are often quite an easy one to diagnose when the patients present without a history of ingestion. In terms of management, supportive care is critical, and acute care is also critical. And we get this right, and outcomes will mostly be good. So we do the usual ABCD. We look for respiratory failure, we look for shock, we provide oxygen or ventilatory support, give fluids with or without dextrose, and treat seizures. In the poisoning management guidelines, we prefer to start with benzodiazepines as first line for seizures, followed by phenobarb or sodium valproate if you need further additional agents to manage seizures. We stay away from phenytoin particularly, as many poisons are cardiotoxic in overdose, and so we don't want to add phenytoin's potential cardiotoxicity to the equation when treating these patients. As always, we optimize kidney and liver function, and if dialysis is required, then we arrange for patients to be transferred to the appropriate level of care. And please do not over-investigate patients. The type of poison and clinical presentation will guide this. So visual bloods are renal function and electrolytes, perhaps sometimes some liver function tests. A blood gas can be helpful, and an ECG where required. There aren't many bedside tests for chemical poisonings. We've gone through the urine dipstick drugs of abuse screens. Those might be available in your emergency departments. If a patient is, if you note that the patient's blood looks very dark, it might be worth considering methemoglobinemia. Prevention of absorption of poisons is always important. The skin and eyes in particular need to be washed thoroughly. We always remind people to use fresh running water or saline, so do not reuse the irrigation solution. So if you're at home, put the patient in a shower rather than a bath. And with regards to the eyes, you may have to give analgesic drops before able to irrigate them really effectively. And then gut decontamination measures include activated charcoal, gastric lavage, and whole bowel irrigation. There's no evidence to support the use of induced vomiting, and so we're really trying to phase this out, although it's very much done within the communities. Charcoal is reserved for substances which are absorbed by it, and many of the chemical poisonings are not. In addition, patient needs to have a protected airway, so either they need to be fully awake and cooperative, or otherwise intubated. And we don't like the patients in between, the ones who are combative and have a reduced level of consciousness, as the risks of aspiration outweigh the possible benefits. And charcoal really has to be given within about an hour or two of ingestion, and so most of these cases are going to present to the primary healthcare services or to the emergency ambulance services. Gastric lavage has very few indications, and so the decision for this is on a case-by-case basis. Usually not so much in the childhood context, really. It's often in adults with large, potentially life-threatening ingestions. And the same for whole bowel irrigation. Very few indications for whole bowel irrigation. All right. Antidotes are few and far between. And really, they are for the minority of poisonings. We really don't see them that often. And so, sorry, I've just lost my, excuse me, I've lost some of my notes here. All right, so I'll speak off the cuff. Antidotes are few and far between, and really they are only indicated when for certain instances, and patients really have to earn their antidote. They have to be systemically unwell enough to be able to get their antidote. These are listed here are some of the more common ones that we see. And really the premise is that certain hospitals will keep an antidote, certain hospitals won't have an antidote. So sometimes it depends on where the patient might present. And so availability can be a problem, particularly in low and middle income countries. And sometimes one has to get the antidote to the patient, or one has to get the patient to the antidote. And sometimes this depends on the logistics within your country. Antivenoms are also something that I need to talk to you about. I'm sure I don't need to educate this audience on snakebite, but just to say that we do see snake bites in South Africa. And we see scorpion stings, and we also see spider bites. And in South Africa, we have our own South African vaccine producers, and we are quite lucky to have them, and they produce a local polyvalent and monovalent snake antivenom, as well as scorpion and spider antivenoms. And I was quite surprised to hear at the recent conference that Sri Lanka doesn't have its own vaccine antivenom producers, and rather relies on having to import most of its antivenoms for the large number of snakebite cases that it has. So really, I'm going to wrap up now, and I hope that I've shown you what potential resources there are available in low and middle income countries, and importantly, how to collect your data and to use it to your advantage. It doesn't have to be complicated. It can be as simple as collecting the cases you see in your hospital and entering them into an Excel spreadsheet. Or there are easy to use databases such as RegCap, which seems to be a common one used in South Africa and affiliated with universities these days. If establishing a poison center is on your agenda and you need to coordinate these efforts, then this excellent WH document can assist you. Importantly, it stresses the health and economic benefits of the existence of poison centers. So please contact me if you have any questions, or perhaps look at our AfriTox website if you'd like to inquire about access. I've also put the important reference links here for you. And thank you very much for your attention.
Thank you very much, Dr. Kavinda, for that excellent and insightful presentation.